Yes, sir, it's visible.
Okay, let's start then. Okay, so the question is, intravenous bicarbonate may be utilized in cardiorespiratory arrest in specific situations. Of the following options, which one is correct? So we have A, increases cerebral output, B, worsens intracellular acidosis, C, severe ongoing hyperkalemia, D, it acts as a positive inotropic agent, and E, enhances oxygen delivery to the tissues. Okay, I think because it's a small group, we can make it just a free-for-all. So why don't you all tell me what you think the answers are?
Is it B, worsens intracellular acidosis?
Okay, and everyone else? I'm afraid I can't see the chat, but I mean, just speak, it's probably easier. What about the others? Just have a guess. So we've got, I don't know if this is going to work. E. So we've got one for that, one for E. And anyone else? Just shout out, don't worry. Or otherwise I'll just have to name names. Who do we have here?
Sir, they are answering in the chat box.
Oh, just answer. I think put all your mics on and then just speak. That's probably quicker and easier. So I can't see the chat, unfortunately.
Yeah, aspirants, please do verbal communication instead of writing in chat box.
Yeah, just say. I think we've got Prakash that's just joined. Prakash, what do you think the answer is? I can't hear. Okay, let's continue. So the answer actually is yes, worsens intracellular acidosis. So in cardiac arrest, you get both metabolic and respiratory acidosis. If you're not breathing to oxygenate your blood and remove the carbon dioxide, then obviously you're going to get a respiratory acidosis because the carbon dioxide builds up. Your heart also is not delivering oxygen-rich blood to tissues, and the CO2 is unable to be removed, so you get a metabolic acidosis as well. So it makes sense, you would have thought, to give sodium bicarbonate in the treatment of severe metabolic acidosis, which we often see in cardiac arrest. And you would expect that would normalize intracellular and extracellular pH, but actually it transpires that it worsens intracellular acidosis. There have been concerns about benefit and harm. This must be, what, 40 years ago, everyone used to get sodium bicarbonate. But I think as time went on over the past few decades, when I became a doctor, certainly, we stopped using it. So in the kind of the 2000s, and the use has progressively fallen and fallen and fallen. And there's a really good meta-analysis that's looked at all the published evidence in this field. And they found that it wasn't associated with any improvement in survival, rate of return of spontaneous circulation, or any kind of good neurological outcome. And the explanation is that bicarbonate is an extracellular ion mostly. It's got a negative inotropic effect. Okay, so it's not positive. So it's something that you probably wouldn't want to give in someone who's got cardiac arrest. Okay, it's negatively inotropic. It does shift the oxygen dissociation curve to the left. Okay, so for that reason, tissue oxygen delivery is actually less. So it's not this one and it's not this one. Okay, so bicarbonate pushes it to the left, so you get less oxygen delivery. It's alkaline in nature, so it can increase extracellular pH, and that's probably why it was given. But if there's no adequate ventilation to wash out the CO2 from the blood, then the hypercapnia can actually decrease the intracellular pH. And from my understanding, that's why you can get the intracellular pH reducing, predominantly because the CO2 builds up. There are some cases where you give sodium bicarbonate in arrest. Can anyone tell me what they are? I think a few more people have joined. We've got Shayam. I can't see very many people here. Sneha and Shyamala, welcome. We're going to try and make this slightly different as kind of a little bit more interactive. Any other causes, any other kind of types of cardiac arrest where you'd give sodium bicarbonate? Generally, as I said, we don't give it anymore. When would you give it? Any idea? I'm going to have to pick on people. Prakash, Ajay, any ideas? Ashri? Reshmi? Any ideas? Come on. Ajay, Pradyut, Reshmi, Shyamala, Sneha, come on.
Sir, is it due to in case of COPD due to the heart failure? Can we give sodium bicarbonate?
In case of metabolic acidosis,
Such
can
as?
give it.
Such as what?
Hello.
Yep, go on.
In case of metabolic acidosis due to heart failure or AKI, we can give sodium bicarbonate.
Yeah, I mean, in the case of cardiac arrest, definitely in COPD and heart failure, I wouldn't give sodium bicarbonate because, as we pointed out here, it causes it causes this intracellular acidosis. But there are probably two cases. One is hyperkalemia, so severe hyperkalemia. You want to reverse the acidosis. The other one is an the other one is an overdose. Any ideas? Overdose? Maybe you guys haven't seen it, but when someone comes in with a tricyclic overdose, you generally give sodium bicarbonate. That is the main reason. With tricyclic overdose, you get kind of a widened QRS, and they often get incessant VT, VF. It's very, very difficult to treat. But the main treatment for that is rather than giving drugs like amiodarone, which is standard of therapy here, you give sodium bicarbonate. But let's quickly go through this. So have any of you ran a cardiac arrest at all? You do cardiac arrests? You must do an ITU. So
Yes, sir.
yeah, so you need to look at this algorithm and make sure that you understand it. Obviously, when you got an unresponsive patient, you give CPR 30 breaths, 2 compressions. The key thing is to intubate as soon as possible. But the most important thing is to assess the rhythm. And if it's shockable, then you obviously give medication. And you can see that in the resus guidelines and in the NICE guidelines, sodium bicarbonate is not anywhere in this piece of paper. Okay, it's nowhere in this figure. The key ones are adrenaline 1 milligram in non-shockable rhythms. But in shockable rhythms, you shock the patient and then you give adrenaline roughly every 3 to 5 minutes. You can then give amiodarone, but that's only after 3 shocks. Okay. In cardiology, we give shocks one after the other, which is a little bit different to this cycle. But that's only if we're in the cath lab and someone arrests. And if they're in VF or VT, then we'll shock them, and shock them again. So 3 times, one after the other. And that's incorporated in the ALS protocol now. But for you guys, you kind of go through this cycle of every 3 to 5 minutes giving adrenaline. You can give lignocaine as well, but I don't think you need to know that. I think the key thing is adrenaline, amiodarone, and also if you think the patient's had a PE or you've confirmed it, so for instance with an echo, then you can think about thrombolysis. And obviously if someone's arrested, you generally give fluids to try and I guess it's because if they're hypovolemic, which is a very common cause of arrest, or GI bleed, then actually you're filling them up, and so you're filling the heart up, and so you're more likely to regain, particularly in PA, I guess, you're more likely to regain return of circulation. Okay, moving on. So let's see if I can clear this. Okay, a 71-year-old lady presents to the ophthalmology clinic with a 3-month history of episodic loss of vision in the left eye. On examination, a carotid ultrasound reveals a 42% stenosis of the left internal carotid artery, as assessed by the North American Symptomatic Carotid Endarterectomy Trial criteria. And also echo was normal. Which of the following is the most appropriate initial therapy for her? So we have aspirin, clopidogrel, warfarin, 𝒃𝒐𝒐𝒐𝒏, or a carotid endarterectomy. Okay, any ideas? And I want everyone to shout out the answer, please. I'm actually very happy if you're in a quiet place, just unmute yourself and then you can just shout it out. I want everyone to give an answer. So Ajay.
Option E, carotid endo.
Carotid endarterectomy. Okay, good.
E.
Okay, anyone else? Sneha?
Sir, maybe clopidogrel or aspirin. I mean,
So clopidogrel, aspirin, yeah.
one of those.
Okay, anyone else?
Clopidogrel.
Clopidogrel. Okay, so you've got a little bit more for clopidogrel. Yeah, I mean, I think so the key thing here, the learning point is NICE guidelines. The MRCP uses the NICE guidelines to design questions, but also the answers. And although in other countries like America or Europe, you may have slightly different treatments, the key thing is you need to look at the NICE guidelines, okay? In terms of carotid endarterectomy, I would have said no straight away. The reason is it's only a 42% stenosis. In terms of delivery of, so if you think about a blood vessel, and if you have a stenosis that's, let's say, 42%, blood flow through that vessel is actually very, very good. And there's lots of reserve and capacitance in blood vessels. To get any reduction in kind of perceivable flow, you really need to go kind of greater than 70%. So it needs to be like this. So as I'm a cardiologist, people only get angina if it's really greater than 70%. And that's when it's physiologically important. There are some people who only get angina with 80, 90, even 95%, okay? So 42% is not particularly high. And I think if you screen, let's say, 100 75 or 80-year-olds in this country, a lot of them will have 42, 50% stenosis without any symptoms at all. So that's the main important point I want you to get across. So these are the NICE guidelines for TIA, okay? And it's really important you go to the NICE guideline website, you can download these. There are some recommendations. I've taken this from the NICE guidelines website, and you can look here, yeah? And for the MRCP, as I say, it's really very, very important that you read through all these guidelines. This came out in 2019. It's been updated in 2022. And as you can see, according to NICE guidelines, they suggest that you offer aspirin 300 milligrams once daily. Okay? Can everyone remember that? Yeah, so they say yes. 300 milligrams of aspirin for a TIA. Now, in the UK as well, a lot of people use this thing called the ABCD score. I tend not to use it, and NICE guidelines say don't use it. But there is a scoring system that sometimes comes up in the MRCP as well. I think the important point that it uses things like age and stroke or weakness. And the important thing to note there is that as the score increases, your subsequent risk of stroke increases as well. So that's really important. And you worry a little bit more if the ABCD score, this is how it's been derived, is 4 or more. And the reason that I don't like it is that you can have patients who are 2 or 3 who are still at quite high risk. But the idea is to risk stratify patients so that if the score is 4 or more, then they need to be kind of brought into hospital and worked up and have things like carotid arteries and brain scans, because the risk of having a problem is much greater. Now, clopidogrel is a drug that I actually really like to use, but it's recommended for ischemic stroke, not for TIA. Okay, so this is for a CVA as opposed to a TIA. So that's the key thing to remember. Aspirin, TIA, according to the current NICE recommendation, clopidogrel for ischemic stroke. Warfarin is really for thrombus, isn't it? So it's for vascular thrombosis. So if you've got like cerebral venous sinus thrombosis, if you've got atrial fibrillation, then obviously you need to be warfarinized. And as I said, dipyridamol is not really first line, and as you may know, people for strokes used to get aspirin and dipyridamol before clopidogrel was around. The only time you give dipyridamol is if a patient can't have aspirin or perhaps can't have clopidogrel. So the first line would be aspirin, second line is probably clopidogrel, but if for whatever reason you're unwell with those, I think then and only then you give dipyridamol, but otherwise it's very much become out of fashion. And as I said, with carotid endarterectomy, it's a very effective therapy, symptomatic and asymptomatic patients, but the key number is more than 70%. So more than 70% after a TIA. Okay, right. Any questions? Questions? Should we move on? Okay. Hopefully this is very easy for all of you. Among the following, which is not a component of the cardiac electrical conduction pathway? So we have atrioventricular node, sinoatrial node, sarcomere, bundle of His, and Purkinje fibers.
Option C. Sarcomere.
C.
Sarcomere. Option C.
Yep. Keep going. Anyone else?
Sarcomere.
Everyone's saying sarcomere. This is a really good question. So yeah, I think that's great. As you all know, I mean, I'll try and expand on the question a little bit. The electrical impulse starts here in the sinoatrial node, where you've just got cells that they just depolarize by themselves, and that dictates the heart rate. And basically the cells which depolarize the quickest wherever in the heart will dictate the heart rate, and it generally is the sinoatrial node. Sometimes you can get an atrial ectopic focus, so it could be somewhere else in the left atrium, or even could be in the right atrium, and if that's the case and it's faster than the sinoatrial node cell rate, depolarization rate, then that will dictate the heart rate. So it goes from the sinoatrial node. There are actually some bundles. You can see there's 3 bundles here, these yellow lines, pathways that go through the left and right atrium, and they enable contraction of the left atria and the right, and then they end up at the AV node. Okay, and there's a short delay there, which allows for the atria to relax, and then the bundle, pulses go through the bundled His, divides into the left and right branches, and that causes depolarization of the right and left ventricles, and then the cycle starts again. On the right here, I've got a picture of a sarcomere. This is an electron microscope of the sarcomere, and you can see that it's really very well structured. It's the basic contractile unit of cardiac muscle, but all muscle really, and they're composed of thick and thin filaments. You've got the thick filaments here, which is myosin. You've got the thin filaments here, you see those, and that's essential for the generation and propagation of mechanical force. And each sarcomere has, what you can see here is a central band, that's called the A band, and you can see that mainly it's the thick filaments there, and there are 2 halves of the I band here, and these meet at what's called the Z line here, and the central portion of the A band is the M line, which you can see here, and you've got no thin filaments there, no actin. And here you can see how you get contraction. You go from here to here. But the key thing to remember here is you've got filaments which are myosin, which are thick, actin, which are thin, and you've also got titin. You may not have heard about titin, but it's, I think as time goes on, you're going to hear more and more about it, because there are lots of cardiomyopathies, which we're finding now where you've got titin mutations. So it's a problem within the sarcomere, and that's why you get things like a dilated cardiomyopathy. Okay, so that's an easy question, I'd hope, for you.